Our next speaker is Shu Zhang. She's also holds a master's, and she's also a doctoral candidate in our biomedical engineering program. And her supervisor and mentor is Elena Vinogradov. And the title of her presentation is CEST mDixon for Breast Lesion Characterization at 3T.
Thank you for your introduction, and good afternoon, everyone. Chemical exchange saturation transfer, or CEST, is a novel contrast mechanism for proton MRI. It can reflect biochemical compositions of tissues. Emergent studies suggest that CEST signal in the MI group range, or the APT signal, correlates with brain tumor aggressiveness and can be used for early assessment for treatment response. These studies motivate researchers to explore CEST elsewhere, so recently, some preliminary studies applying CEST to breast malignancies come out, and these preliminary studies suggest that CEST has a potential of tumor detection, characterization, and treatment assessment. These preliminary studies captured our interest, and we hypothesize that CEST MRI can provide metabolic information to enhance the specificity and predictive value of MR mammography. The work presented today is our pilot study. Another motivation for us to apply CEST to breast imaging is from technical development perspective. We would like to test the performance of a novel CEST imaging method that separates water from fat, the CEST mDixon method. I'll talk more about this method in later slides. Although there are some preliminary studies, but these studies did not explore the CEST application systematically, and there are still unanswered questions. First of all, it remains unclear whether the CEST effect how the CEST effect will change in malignancy. It will go up or go down. Second, no consensus has been reached on which CEST range had the highest correlation with breast malignancy. Third, what is the optimal CEST imaging strategy in human breast remains unknown, not to mention what are the major biochemical contributors to the CEST effect in breast malignancy. Therefore, we'd like to explore the CEST application to breast malignancy systematically and offer answers to these questions. The first question to address is question number 3, which is related to our second motivation. The question is, what is the best way to collect CEST images in breast? One big challenge for breast imaging is fat contamination. For CEST application specifically, fat signal degrades CEST contrast. Here I use a simulated APT-Z spectrum with and without fat to explain why. As here, and the red is with fat and the blue is without fat. As shown here, the fat has its main peak sits around 3.4 ppm upfield, and it is right on the opposite side of the APT signal with respect to water. And therefore, the fat will affect the APT signal most in the MTR asymmetry analysis. MTR asymmetry, as shown here, represents a CEST contrast, and we can see clearly here the red has lower CEST effect than the blue one. Besides CEST contrast degradation, fat dips also overlap NOE effects. There are several methods to reduce the lipid artifact currently, as listed here. Compared with other methods, Dixon-based methods are insensitive to B0 and B1 inhomogeneities. They have less interfere with the saturation pulse train, and the intrinsic B0 mapping feature of this method benefits CEST imaging. As a result, the CEST sequence combine the mDixon acquisition with the saturation pulse train of the CEST imaging becomes our first choice for fat-free images, and this method is the so-called CEST mDixon. We apply this sequence to 5 female human subjects, 2 healthy volunteers and 3 breast cancer patients prior to biopsy and later confirmed carcinoma. All the scans were performed on the 3T Ingenia human scanner. 2D multi-shot T1-weighted TFE sequence with 3-point multi-echo Dixon are used for image acquisition. The total saturation is 500 milliseconds with B1 RMS about 1.2 microtesla. 33 points in the Z spectrum from -6 to 6 ppm are acquired. And here shows the representative images, and the Z-spectra for a healthy volunteer and a patient. And the Z-spectrum are corrected using the Bezier maps derived from the mDixon method. For the Z-spectrum, we can see two things. One, the malignant tissue has higher CEST effect than the normal tissue. Two, the normal tissue is wider than the malignant tissue. We explore the two indications more here and the next slide in order to offer answers to the question number 1 and question number 2. These bar plots shown here are the MTR and symmetry averaged in the three CEST ranges, the hydroxyl group, the amine, and the amide group. Here we can see that for all the three CEST ranges we explored, malignant tissue has higher CEST effect than the normal tissue. And for the hydroxyl group here, although it has larger deviations across patients, it has higher CEST effect in malignancy and has lower CEST effect in normality. Hence, the difference between malignant and normal is larger in this group than the other two groups. Here, the bar plots shows the width of the Z-spectrum, and it becomes evident that the malignant tissue is narrower than the normal tissue. The Z-spectrum acquired with and without Dixon are compared. The no Dixon spectrum is actually from the first echo acquired using the mDixon method, and the with Dixon spectrum is from the water-only images. And here, as the blue arrow shows here, there is a fat dip can be seen in the no Dixon spectrum, and this fat dip results in another dip in the MTR and symmetry, which makes MTR and symmetry negative. So in the CEST maps, we can see a lot of negative values, especially at the edge of the fibroglandular tissues. This fat dip is removed in the with Dixon spectrum, and the MTR and symmetry becomes positive again, as the red arrow and the CEST images shown here. The bar plots of the MTR and symmetry also compared. It becomes evident that the APT signal from the no Dixon spectrum is much lower than that from the with Dixon spectrum. And larger deviations are observed in these bar plots too. Compared with the APT signal, the other two groups are less affected by fat, but with increased variations. The widths of the Z-spectrum are compared as well. They are less affected, but the with Dixon, but the one comes from the with Dixon spectrum tends to be a little bit wider. Overall, CEST mDixon sequence is robust, and water fat decomposition leads to homogeneous fat removal in the water-only images. Human studies demonstrated marked difference in MTR and symmetry in all three ranges, and the width of the Z-spectrum in healthy versus malignant breast tissues. The results suggest that mDixon-based CEST MRI has the potential for robust detection and characterization tool, has the potential as a robust detection and characterization tool for the breast malignancy. In the future, we are going to address question number 4 by correlating the CEST contrast with different breast tumor types, aggressiveness, and also with the histological studies and biochemical markers. That's all. Thank you for listening.
Are there any questions? Yes, there's a question there. Marco.
Thank you. Very interesting presentation. You did show some differences between CEST signal in malignant tissue versus normal tissue, but I'd like to know if you've measured CEST signal, the variability of CEST signal in normal tissue, how much that variability is, and how different is CEST signal in malignant lesions compared to the variability we would expect in normal tissue.
Here the bar plots show the MTR and symmetry, and we explored it in the 3 ranges. And the gray one is from the malignant tissue, and the white one here is from the normal tissue. And here you can see that for this hydroxyl group range, it has larger variations. But here for the APT signal, it has lower variations here. And it also in the here for this hydroxyl and amide group amine group, the variations in the malignant tissue is larger than the normal tissue. But right now we did not explore like how much variations we expect. Here is the pilot study just to differentiate just to see whether this method can differentiate between the malignant and the normal.
So I have a question. So when you look at this hydroxyl group,
Sure.
there's a literature on differences of exchanging hydroxyl-containing compounds in malignant versus benign, right? So can you guess at what's causing this CEST effect?
You mean like some kind of biochemical?
Yes. Or is it too early to do that?
Yeah, there is some guess that we have some preliminary studies showing that like choline might be a possible contributors, and also we have underglycosylated mucin 1 as possible contributors to this. And I think there's a lot of other possibilities too, but here is two reported by the literature.
Thank you.
Yeah.
Yeah. Oh, Neil.
So I think this is pretty exciting, and I'm just wondering, do we have any mammographers here, any of our breast imagers? I saw Emily before. I guess not. So what is the next step to roll this out? Because ideally, you've shown some very interesting preliminary data, but you'd like to do this in a variety of cases in a larger number, do box and whisker plots and see if you can really separate this out, and then compare it to DCE. It's a fantastic opportunity. So I'm wondering, when is this going to be ready to roll out into a clinical trial?
So yeah, this study here is our pilot study. So our next step will be increase the number of cases we study and try to correlate the CEST signal with different aggressiveness and tumor type to see whether this method is capable of doing grading or like do the treatment response. And we also would like to correlate the studies with our biochemical studies as well to see which is the major contributor of this CEST effect.
Good. Thank you. Our next speaker is